Welcome to Public Health on Call, a podcast from the Johns Hopkins Bloomberg School of Public Health, where we bring evidence, experience, and perspective to make sense of today's leading health challenges. If you have questions or ideas for us, please send an email to publichealthquestion@jhu.edu. That's publichealthquestion@jhu.edu for future podcast episodes.
This is Lindsay Smith-Rogers. Today, Dr. Josh Sharfstein speaks to Linda Villarosa, a contributing writer at the New York Times Magazine and the author of an award-winning book on racism and health. They discuss the reasons why Black Americans have experienced and still experience elevated rates of death at every age. This conversation is being released during Black Maternal Health Week in the United States. In our next episode, Dr. Rachel Burville, an MPH student at the Bloomberg School, and producer Annalise Winnie dig into why Black women and their babies are particularly at risk of dying. Let's listen.
Linda Villarosa, thank you very much for joining me on Public Health on Call. I'm very excited for this discussion. I read your tremendous book, Under the Skin, The Hidden Toll of Racism on American Lives and on the Health of Our Nation. I want to start with a basic question. What drew you into this topic?
Well, I was the health editor of Essence magazine back in the late 80s and early 90s and was really shocked by the racial health disparities. And there's never been a time in America where Black outcomes have equaled white health outcomes or even been close. That gap bothered me. And it starts at birth with infant mortality, where Black infants are more than twice as likely to die as a result of being born, and then all the way to death when life expectancy is much shorter for Black Americans.
So you're the editor, the health editor. What was your first approach to this question? That what could be behind these enormous disparities in health?
As a health editor of a magazine, and a magazine that was about racial uplift, my idea was to say, if everyone understands, all the readers of the magazine, and we had 1 million subscribers at that point and 8 million readers, if everyone knows better, they'll do better. And if I just give more information about what to do, and, I was working on a self-help model. It's like, if you know better, you do better. If you take better care of yourself as individuals, and everybody does it, then it will change the health outcomes of African Americans as a demographic.
The unstated assumption is that the source of the problem is just lack of information.
Yes, or doing something wrong. Maybe you know a little bit something, kind of what to do when you're pregnant to keep your baby healthy, but let me give you even more information on prenatal care. Or what you're supposed to eat, but maybe to avoid heart disease and diabetes, but maybe I give you some more sophisticated information and culturally sensitive. So I'm telling you, you can still eat some of the same things you want, but maybe you shift it a little bit so that you're having less salt or you're having less sugar or something like that.
Yeah, it's a pretty common way to think about health problems, is that it's just about what someone individually can do. But in your book, you talk about the limits of the explanatory power of that framework and how you began to see the problem of racial disparities a little more broadly.
And I think that there's nothing wrong with helping people understand what to do correctly, but that's been done over and over. It was the only way that we were thinking, if we just focus on individuals and in the same vein, blame them for the health outcomes of the whole race, then we can change things. And I think that is just never going to work. Although for individuals, it's really good to take care of yourself and to exercise and to eat well and to take care of yourself when you're pregnant. But it's still, no matter how hard you as an individual work, we're not going to change the health outcomes of the race as a whole.
And that's because there are some systemic issues that are driving these disparities. And in your book, you lay them out, starting with history.
Well, history is very interesting because even with this book, I thought I was going to start around 1850, around the first time that real census numbers came out by race. And then I was part of the 1619 Project, and I went back further. Once I started looking into the kinds of things that were happening to enslaved people in the name of medicine and science, the cruelty that was happening, the myths that were used to justify enslavement, and then the through line to today that some of the same myths are still floating around in medicine, in science, in medical training, and in medical practice, then it became a different story. It wasn't so much about individuals taking care of themselves, but it was about looking at the forces that prevent people from being healthy.
Today, somebody might say, well, that's going to be different. Infant mortality is going to be higher because Black babies are somehow different. But that concept that they're different has a long and sordid past.
And I understand why it was, especially for scientists and medical people, to jump to genetics. But it's been well proven that anytime we talk about genetic differences and genetic racial differences, the underlying assumption is an inferiority, that something's wrong with the Black body. That is what is creating this problem of, say, infant mortality and by extension, maternal mortality. What is really at work here is something really different. And it has to do with institutional and barriers and structural barriers.
So starting with these misconceptions, you then have the challenge that exists in accessing quality healthcare as another systemic issue that someone is not going to fix by changing their diet, for example.
And actually, even the more work I've done, the more I don't even like to talk about access to healthcare. Because when you have community people talking to people from the institution, say the hospital or the healthcare center, the people from the institution, the doctors and the healthcare providers are saying, oh, what we need to solve this problem in the community, whatever it is more access to healthcare. And then the people in the community are saying, we know that this healthcare system exists, but we don't like to enter it because we don't trust it or we've had bad experiences. But certainly the overriding bigger picture is that everyone should have free universal access to healthcare. But once we solve that problem, which doesn't seem very likely in this country in the near future, then we have to look at what is the healthcare system people are entering and does it treat everyone equally? And the answer to that is no.
You write about some really compelling stories where there have been some tragic outcomes as a result of people being dismissed by the healthcare system, not getting the care that they need. And you find that when that happens, it makes it even harder the next time for people to want to seek care. It's almost like a vicious circle.
And it makes sense. And it's not just what happens to them personally, it's to them as a human being, but it's their loved ones and their neighbors and their friends and their community members. So if people in the community are talking about this happened to me in the healthcare system, then their neighbor is also going to say, well, maybe I don't want to go to the doctor either. And you saw this conversation around COVID. And so there was this conversation, they were calling it vaccine hesitancy about vaccines. They were talking about the testing. Black communities weren't wanting to get tested. Two things were happening then. First, testing wasn't always available in those communities. And second, people were really distrustful of the idea of COVID in the first place. And immediately you could turn on the TV and see protests where people were saying, well, wait, if Black people are the ones who have the worst health outcomes, why do we have to be punished for it? And so all of that kind of the political thing happened in the middle of this idea that Black people are distrustful of the healthcare system itself. So I think it got really messy and it all showed up when COVID started.
So you have historical misconceptions, you have mistreatment by the healthcare system and the distrust that that can engender. You also talk about other systematic reasons for these major health disparities, including place-based problems where people may live in less healthy communities with less access to clean air, clean water, as well as other types of systematic barriers. Could you talk a little bit about that beyond the healthcare system?
When you think about the so-called social determinants of health, and I don't even like to use that phrase because you're really talking about where you live and work and where you spend most of your time, your community. And those communities, because of segregation, have been systematically, many of them, Black communities, have been destroyed and have been left less healthful. So Black people are 75% more likely to live near a polluting facility. So that means refinery, a garbage dump, a landfill. So that right away is unhealthy. If that community is then punished through redlining because it's less healthy or there's some polluting facility, then there's just less wealth. You can't buy your home because you can't get a mortgage there. Or redlining was in the past, but the effects of redlining remain. In the community where my mother was from, Inglewood in Chicago, people only lived to age 60, and it was redlined. So at the time my family was trying to buy a house there, they couldn't buy a home, even though they had the money, because Black people weren't allowed through redlining. So they were subcontract buying, which meant that they had to buy their home at a higher price. They had to buy their home only on a contract with no equity. And if they missed a payment, they could lose it. My grandfather did not lose his home, but millions of other people did. And it sucked away $3 billion of wealth from that community.
Well, even now we're seeing the different valuation of homes, perhaps based on race. And we've had some pretty stark examples of that recently, even in Baltimore.
Definitely. I think it just speaks to the connection between health and wealth. I don't think wealth is exactly the word we want, but I like the rhyming. But it's about what the community has to offer, the assets. Do we have clean water and clean air? Do we have affordable, healthy food, access to quality education and housing and things like that? But if you don't, then it just makes it harder to be healthy in the community.
And I was going to say that your book goes even further to mental health challenges and stress experienced by Black people and the health impacts that those challenges have. And it all adds up in your telling to the impact of racism on health.
And part of it is just the impact of racism of society on the body. And the way I know it most is a kind of accelerated aging. Dr. Arlene Geronimus, who I think her book comes out right now. It just came out. It's called Weathering. And it's about the concept she created when she began thinking about it as an undergraduate at Princeton and has been thinking about it for decades ever since. And that's the idea that as you have to strive against discrimination in society and push against it, it creates a kind of premature aging to your body that she calls weathering. And weathering shows up for the way she first studied it was infant mortality. And so when she was looking at teen pregnancy in like the 90s, and teen pregnancy was being blamed for the high rate of infant mortality in the Black community. But what she found was it wasn't infants dying of teen mothers, but dying of women who were a little bit older. And her early hypothesis was that was because they had had a worse lived experience in America for longer. And now she has really explored that hypothesis. Her book is really good. You're going to be hearing a lot about it. And it really speaks to a lot of people of the idea that each time that you get angry or you get upset or you're treated poorly, it changes the system of your body. And when it happens over and over, it can cause really long-term damage.
So your book is very compelling in its explanation and beautifully written, and also will be hard for some people to understand if they're trapped in the model that we talked about at the beginning, that this is really about what people can do for their own health. And I wonder if you were to go back and be the health editor of Essence or be the health editor of any other magazine today with a large audience, how you might try to cover this differently. How can people talk about this problem in a way that points to these more fundamental issues rather than just individuals' behavior?
I think even at Essence, I had started to change because at the beginning, I was saying, do everything right, including trusting your physician. And you need to go get these checkups and tests that you need, and you need to really listen to your doctor. And by the end, after I had gone to public health school, I stopped saying that. I started saying, take someone to the doctor with you if you have to enter the healthcare system. Do your best to be healthy so you stay out of it. Certainly learn as much as you can about whatever is going on with you so that you are an educated person. Don't just blindly trust our healthcare system. I think right now I would also ask for a much more political lens. I had started doing that already when I was at Essence, but I would do it even more. I think that one thing I did later in my career was looking back at the reasons why and having a more sophisticated take on all kinds of disease. Maternal mortality was the one I looked at most. And the early thinking about that was it's either something genetic or something that women are doing wrong. It took me a while to figure out that it was not that. And even it took me a minute to be in the delivery room with a Black woman who I saw being treated extremely badly, even though she had had a stillbirth the year before. And even though it was clear that she was getting more and more agitated by the mistreatment, which was affecting her labor in the moment. So I think that it took me a while to really, and it doesn't feel good to say, oh, the systems of our country, including our healthcare system, don't always treat us fairly. And it's hard to even figure out. I hate even talking about it sometimes because I can see people's faces get really worried. But I do want to say that I still encourage people to take good care of themselves. But I also encourage people not to just blindly believe in the systems and to do the history, read the research. There's certainly so much writing out about this now, including my own book.
Well, I think your article on maternal mortality was one of the most influential pieces. It really exemplified how if you can tell the story of someone really experiencing this overall challenge, you were able to take a huge systemic issue and tell the story in a way that was really personal. And I think it's one of the major reasons why the country cares so much more now about the disparities in maternal mortality. And I'll just say, I did not realize that you went to public health school when we're doing this, but I think maybe it's just great for the field to know that it contributed to your tremendous understanding and writing on this topic.
I had a fellowship for health journalists, and it was really so valuable because it really shifted my perspective. Also, it confirmed that I'm really not that great at math. But I really enjoyed the experience, and it was transformative for me.
Well, your writing is spot on in terms of the statistics. So I think that is not anything to worry about. Let's talk for the last minute here about what can be done. You have, I think, helped to trigger an appreciation of some of these fundamental issues. There is legislation in Congress focused on maternal mortality and disparities. There is a big investment by the Biden administration in community health workers and outreach trying to break down the distrust that exists with the healthcare system. When you take a deep breath and think about all of what you have worked on and your own conception of the problem, are you filled with pessimism, optimism? How do you take stock of where we are right now and where we're headed?
I'm really optimistic, especially because a lot of my last almost 8 months has been on talking about my book at medical schools, at midwifery and nursing schools. I just came from a school of health professions, and that's even broader, and talking about these issues and seeing people who are students, they're the healthcare providers of tomorrow, seeing their eyes open. And some of them, their eyes are already open and they're trying to be different kinds of providers in the future. And I find that really thrilling. I find the interest in my book by the faculty, the administration, the staff of colleges and medical schools, nursing schools, really wonderful. But it's really the students who there's a lot of energy going on. And I think the change has to come up from the ground up, but also from the top down. And so when you see the AMA is trying to move the needle, the NIH is trying to move the needle, there are organizations and agencies that are trying to do things differently. And I think we just have to, as consumers and as the public, make sure that it's not just words only, because we spent a lot of time admiring the problem without taking concrete action. But I feel positive that this is a time when things are really moving forward and there is action towards solving some of these problems, and especially the problem of discrimination in the healthcare system itself.
Well, Linda Villarosa, thank you so much for talking to us about this incredibly important topic. And I'm going to be optimistic if you're optimistic. I sense your hope for the future, and I think it's all of our responsibility to make that actually happen. So thanks so much for joining me.
Thank you. I really appreciate talking to you.
Public Health on Call is a podcast from the Johns Hopkins Bloomberg School of Public Health. Produced by Joshua Sharfstein, Lindsay Smith-Rogers, and Stephanie Desmond. Audio production by J.B. Arbogast, Holly Cardinale, Philip Porter, Spencer Greer, and Matthew Martin, with support from Chip Hickey. Distribution by Nick Moran. Production support from Catherine Ricardo. Social media run by Grace Fernandez and Shian Briscoe. If you have questions or ideas for us, please send an email to publichealthquestion@jhu.edu. That's publichealthquestion@jhu.edu for future podcast episodes. Thank you for listening.